Everyone. Welcome to on a rainy Friday afternoon. My name is Alan Greenberg. I'm the director of the DC CFAR, and we're incredibly excited about the seminar this afternoon. Last night, the DC CFAR Scientific Interest Group on Latinx had a fascinating presentation by Deanna Kerrigan on the importance of provider-patient communication regarding PrEP use. And so it was a great, I think, prepared all of us to really think about the important issues you're going to be presenting on today. So anyway, thank you for organizing this, and over to Rachel.
Thank you so much, Alan. So this talk was, or this seminar was a suggestion by Martha Cameron. So I want to thank her for that suggestion. And it's very much inspired by the updated US perinatal guidelines specific to breastfeeding in women, breastfeeding and chest feeding, I should say, in birthing individuals with HIV. And the updated guidelines are a shift that really emphasize the importance of patient-centered care and shared decision-making around infant feeding. And while they recognize a persistent low risk associated with breast and chest feeding, they really emphasize that shared decision-making between providers and patients is really critical, and the role of providers in educating birthing individuals and their families about all their options to empower them to make the best decision for them and their family in terms of what's safest and right for them. And this shift is responsive to both updated data that Dr. McKinney and CC will review, looking at the minimal risk of breast and chest feeding in individuals with suppressed viral loads, but is very much in response to the collective voice of community members and advocates who have called for more inclusive infant feeding and specifically counseling and support for infant feeding. So without further ado, I want to introduce our two speakers. Ciara CC Colvin is a survivor of HIV for more than a decade, diagnosed at the age of 20 in a small rural town in the southern region of the United States. She's both professionally and personally committed to advancing the dialogue around HIV and breastfeeding. And as a woman living with HIV, CC was able to advocate for support from providers to breastfeed her youngest child for 7 months. Additionally, in the role of program manager at the Well Project, CC's been able to leverage her voice and experience to advocate for women living with HIV. We'd additionally like to welcome Dr. Jenny McKinney, who's an assistant professor of maternal fetal medicine at Baylor College of Medicine. Her research interests include infectious disease and pregnancy, as well as public health program design and implementation. She currently leads clinics caring for women, pregnant individuals with HIV and substance use disorders within the county hospital system in Houston, Texas. And she's been involved in efforts to improve care for these communities on the local and state level. So without further ado, I'd like to give a warm welcome to both of them. And thank you guys both so much for being here.
Thank you so much for the introduction, Dr. Scott. If at any point you guys can't hear me or I freeze or something, just say something. I'm on our county hospital Wi-Fi system, which sometimes isn't the most reliable. If you hear any security announcements, I'm in clinic. So with that disclaimer, I will go ahead and get started. Maybe if I can get this, there we go. So disclosures first, I have nothing financial to disclose. I do want to disclose up front, I'm an obstetrician. That's my training. And so I know a little bit about the pediatric side from the care of all of my patients. But I would definitely ask any of you who have pediatric specific questions, remember that the perinatal HIV hotline run through UCSF exists, 888-448-8765. And you can call that number at any point to discuss a case, whether it's from the pediatric or OB side, with a national expert. I also want to disclose that, I have had the privilege of being supported in my breastfeeding journeys with my own children. And so I cannot speak to the patient side of this, and I am just so grateful that CC is able to be with us today to help us understand from her point of view. Today, I'm going to just kind of summarize the current evidence guiding infant feeding practices for people with HIV, describe some factors that influence infant feeding decisions, and then give a brief overview and some suggestions about how providers might be able to better support patient infant feeding decisions, no matter what they are, before, during, and after delivery. These are some questions. We'll come back to them at the end, but just kind of be thinking as we go through the talk. Risk of HIV transmission via breast milk from a breastfeeding person on antiretroviral therapy with a consistently undetectable viral load is. The second thing to think about is whether formula is always acceptable, feasible, affordable, sustainable, and safe for individuals with HIV in the United States. And the third question includes some reasons that people with HIV choose to give breast milk for their infant include health benefits, fear of disclosure, infant bonding, family expectations, planned travel out of the country, or having breastfed at prior infants in other countries. So again, hopefully we'll answer all of these and we'll do a quick quiz at the end. The first thing I want to talk about is just how much words matter, especially in this topic. I mean, everywhere in medicine they are, and I just want to be really intentional about what words we're going to use during this talk. First of all, I will be trying to use person-first language when at all possible. I want to make sure we center the person, instead of this is a person with HIV or a person with diabetes. This is not a diabetic person. That person is first and foremost the most important, and I'll try to use language that reflects that. In terms of words pertaining to transmission, perinatal transmission will be the words we use to talk about HIV transmission from a mother to her baby during pregnancy or delivery. This is perinatal transmission is the preferred term right now instead of mother to child transmission. That terminology is older and really imparts some sort of blame to that transmission, which is not productive. In terms of talking about transmission during breastfeeding specifically, we're going to be talking about lactational transmission. When I talk about lactation in general, I'm going to be using breastfeeding mostly for simplicity's sake throughout this talk, but I do want to recognize that there are a lot of other terms that other people may prefer, including chest feeding. We'll use gender inclusive language where at all possible. The exception will be when I review data, when I will present the results in the same terms that were used in the original publications. So with that, I'd like to just start with a quick overview of the history. And I think it's helpful to start with something that's slightly easier, or I guess has more clear-cut answers at this point, which is perinatal HIV transmission. And so starting, prior to any antiretroviral therapy, we're looking about a 25% risk of transmission. So this is for, a mom who was not on medication during pregnancy. When you add on zidovudine, either during pregnancy or labor, and then for the infant about after delivery for about 6 weeks, you can get down to about 8%. If you add on good maternal antiretroviral therapy, you get down to less than 1%. And for someone who comes into pregnancy on medication with an undetectable viral load at conception through pregnancy and at delivery, there have been 0 documented transmissions over time. And so those are kind of pretty good numbers, and we have a pretty good idea of how to avoid perinatal transmission. These are where those guidelines in terms of who do you give intrapartum zidovudine to? When do you recommend a C-section? Really only if that viral load is greater than 1,000. These are all pretty clear-cut guidelines, and I would say most providers are very comfortable with these. Lactational transmission is a little bit different. We know that the baseline risk of transmission via breastfeeding prior to the availability of medication is about 16%. Transmission, once you start adding on antiretroviral therapies, so first of all, if you look at women who are continued on antiretrovirals until weaning, you get that number down to about 1 to 3%. If you just give babies medications for that first week of life, you're like 5 to 10%. And if you continue babies on meds throughout breastfeeding, you're again down to about 2%. And a few studies that have looked at it show that there's really not a whole lot of difference between either having moms on antiretrovirals or babies on antiretrovirals. The caveat with all of these numbers is that these are some older studies where the actual viral suppression of the mom wasn't really considered. And so the best study that we have that gives us that piece of information is something called the PROMISE study. And this was a multi-site randomized controlled trial that was mainly done in sub-Saharan Africa and India. And the trial was actually designed to compare maternal antiretrovirals to infant antiretroviral, or infant prophylaxis, after delivery during breastfeeding. And when they looked at the numbers I'm showing are just from the maternal antiretroviral arm, but the numbers are similar for the infant arm. And what we see is that about 6 months, you're having 0.3% chance. It's about 3 in 1,000 risk of transmission. That increases a little bit at 9 months, you're up to 0.6, and then really stabilizes at about 0.7 up to 18 months. One thing to note from this study is that there were 2 transmissions that occurred when patients had an undetectable viral load. And I've showed a picture here on the bottom right corner of one of these cases. And you can see there the stars show you that where the infant tested positive. And if you can see at the time that the infant tested positive, the maternal viral load, which is that dotted line at the bottom, was at undetectable. However, if you notice that from delivery to that time, that viral load was detectable. And so it is less concerning in the sense that the viral load was elevated previously, but because of these 2 cases of transmissions, we can't say absolutely that someone with an undetectable viral load cannot transmit to baby via breast milk. Things that we know from a variety of studies that might increase transmission via breast milk include acute HIV infection. Suboptimal viral suppression has definitely been shown to increase transmission via breast milk. The problem with this is we don't really know the details about this. We don't know, how high does the viral load have to be to impart increased risk? And we don't know for how long. Does it matter if someone blips up to 50 for a couple of weeks and then comes back down? Does it have to be, a couple of months? Is there, a cutoff like there is for perinatal transmission greater than 1,000, where that seems to be an issue? And we just don't know that for lactational transmission. We know in general that lower maternal CD4 count can be associated with increased transmission during breastfeeding, but we don't really have good data for that in the era of good modern maternal antiretrovirals. The PROMISE study that I mentioned, their cutoff was a CD4 count greater than or equal to 350, so we just don't know. Mastitis, has been shown to increase transmission. We always assume where there's inflammation, there's virus. And so that's definitely a possibility, but we don't have good data in the era of antiretrovirals with optimally suppressed viral load that this is still an issue. Nipple trauma with bleeding, again, does this matter if someone's viral load is undetectable? We don't know. And finally, mixed feeding is something that has gotten a lot of press in the past. There is some older data that seems to show an increased risk of transmission via breast milk if breast milk is alternated. And the older data really was reporting on mixing of breast milk and solids. And the thought was maybe there was some irritation to the infant gut that could increase transmission. I will say that we have no data that this is even a consideration or an issue in the area of maternal antiretroviral therapy. So one good example to show for that is the PROMISE study. We know this was a real world cohort. People were out there, anybody who's ever breastfed knows, at some point, most people have to give some sort of supplementation. People introduce solids early. And the reassuring thing about the PROMISE trial is, despite it being real world experience, those transmission rates were extremely low. And so the national thoughts right now, even though we don't have specific data saying definitely mixed feeding doesn't increase transmission if your viral load is suppressed, this is not a consideration, and really shouldn't lead to people having to stop breastfeeding if, for example, they have to supplement with formula. So in summary, kind of what we've talked about, I feel like it's helpful to put this in the context of what we know about U=U in general. So pre-conception, if a partner living with HIV is taking medication daily, has undetectable viral load, they cannot transmit to a sexual partner. During pregnancy, if someone is on medication prior to pregnancy, has an undetectable viral load throughout pregnancy and delivery, there have been 0 transmissions, so U=U during pregnancy. During lactation, I think I demonstrated mainly from the PROMISE study, that's really the best data we have at this point, that the risk appears extremely low, but we can't say 100% for sure that U equals U during lactation, and each individual really must do their own risk-benefit assessment. Even if there is a residual risk, I think it's really important to talk about the alternative to breastfeeding for most people is formula. And it used to be thought in some of the initial guidelines that really recommended replacement feeding in high resource settings were really based on the thought that, well, formula is acceptable, feasible, affordable, sustainable, and safe for all people with HIV in high resource settings, including the US. And I just want to bring up a couple examples to question that issue. First of all, is it feasible? We all just lived through this formula shortage. People had a really, really hard time finding the appropriate formula for their baby. I had multiple patients that expressed concerns during their pregnancy. What am I going to do? I've had a friend that is driving to 8 stores a day trying to find formula. So this is definitely not a slam dunk in high resource settings. In terms of it being affordable and sustainable, I'd like to remind you there's no mandated coverage for formula with parents with HIV in the United States. There are definitely some areas and some states that have provided coverage for this, but it's not routine over the entire US. Many people may be planning to travel to countries without clean water after delivery. I had a patient from India that was planning to take her baby to visit her extended family and was going to be gone for a couple months. And she knew that she wouldn't be able to find access to clean water and formula in India. In terms of formula always being safe, I think that there are a couple examples in the United States that show that drinking water is not always safe in the United States. We just had a boil water notice in the last 2 months where basically the city of Houston was like, hey, everybody has to go out and buy bottled water, which obviously is going to be an issue for some people. In terms of whether or not formula feeding is acceptable, I think it really depends on the person. There's really, we all know there's a huge high stigma associated with HIV in general. I've had multiple patients that say, hey, if I don't breastfeed, my community, my family, my friends are going to know I have HIV and I'm not going to be able to hang around them. They're not going to let their kids play with my kids. And that's just not acceptable. There's a lot of patients that there are very good data supporting all the health benefits, both for mom and baby. And that's what this diagram is kind of outlining here on the right side. And I think Mariel Gross, who wrote this paper in Journal of Law, Medicine, and Ethics, just makes a really nice point that, current recommendations against breastfeeding likely further disadvantage already in disadvantaged groups, largely due to existing socioeconomic and racial disparities. Unfortunately, minority women suffer disproportionately from diseases breastfeeding may prevent. And I think it's just something really important to consider. I also have patients that they feel like breastfeeding is a really, really important part of bonding with their infant. And sometimes that plays into their infant feeding decisions as well. So with that, I just want to talk about where we are for the United States in terms of perinatal guidelines. So before 2015, there really wasn't much, there was nothing mentioned in the perinatal guidelines about breastfeeding. Around 2015, that's where there was first some acknowledgement that individuals may face environmental, societal, familial, and emotional pressures to breastfeed despite the risk of transmission. And then 2018, a full section on breastfeeding was added, but as you can see here, there was, bold in the first bullet point was that breastfeeding is not recommended for individuals with HIV in the United States. This all changed as of 2023, where the new guidelines came out at the end of January of this year. And they now say the first bullet point, people with HIV should receive evidence-based, patient-centered counseling to support shared decision-making about infant feeding. The counseling should begin prior to conception and should be reviewed throughout pregnancy and again after delivery. And it points out that during counseling, people should know that replacement feeding does eliminate any risk of transmission. And it also notes that achieving and maintaining viral suppression is really important and decreases that breastfeeding transmission risk to less than 1%, but acknowledges not zero because of the PROMISE study that I mentioned earlier. It also mentions that people who are not on antiretrovirals or do not have a suppressed viral load during pregnancy, they've chosen to stay at a minimum through the 3rd trimester as well as at delivery, should be encouraged to replacement feed. It says that people who decide to breastfeed should be supported. People who decide to formula feed should be supported. And finally, I think a really important point is they specifically say now engaging child protective services or similar agencies is not appropriate to infant feeding choices for a person with HIV. And I think this is something that is heartbreaking just to hear. You know, I've had a couple of my own patients that, you know, have gone to WIC to get a breast pump, and the WIC person finds out they have HIV and calls CPS, and they get a call the next day. You know, talking to another member of the community yesterday, she was just sharing how often she still gets calls even after these guidelines have been published that CPS is called for this reason, which just isn't appropriate. This is just something I want to highlight. This was an interesting paper that came out of a group of UCSF recently, and just was a survey looking at providers who care for pregnant people with HIV in the US, and kind of the range of their responses and thoughts about breastfeeding. And it kind of ranges from provider discomfort. Well, you know, I feel the need to protect the infant and think it isn't ethical to put the baby at risk. Some people recognize patient autonomy. I will always support and provide care for individual who desires to breastfeed, even if it's not my recommendation. To paternalism, where someone is like, well, I'm going to try to persuade them to formula feed, or, well, this isn't in our hospital policy, so we can't support that, or it's just not safe to because of medical legal concerns. And so I think it just demonstrates that there's a whole range of thoughts in terms, and these were all patients these were all providers, by the way, that volunteered to respond to this. So hopefully had at least some sort of interest in the topic. So you can just imagine the range of thoughts and attitudes in the rest of the country. So I just want to take a couple of minutes just to briefly talk about how we've incorporated this into our practices. This is not a perfect model by any means, but hopefully we'll give you an example of kind of how we've thought about it and give you some food for thought in figuring out what works best for your own individual locations. So we start discussion about infant feeding at the very first visit. We usually talk about just common myths. You know, I have a lot of patients that come in and the first thing you say to me, well, I need to have a C-section, and we talk about that. And they usually, the next thing they follow up with is, I'm not allowed to breastfeed. And that's the first thing I address, is that this is not about being allowed or not allowed. This is something where my job is to make sure you have information, you figure out how it works and what's the best answer for your family. So we started addressing it at the first visit. We kind of continue to answer questions, discuss things over the next visits, and usually by about the end of the 2nd trimester, if they're still interested in breastfeeding, we set up a consultation with our pediatric retrovirology team, and that'll be the team that'll be following the baby for HIV monitoring after delivery. We make sure that we have a plan, what's called a plan of care, that just kind of is a standard counseling guide for the patients, that is signed by the patient, the OB team, and the PEDS team, just to make sure we're all giving the same information. We make sure to start getting an electric breast pump as early as possible. And we've just started a program where the medical director of lactation, IBCLC, actually comes into clinic and meets with the patient prenatally, just to talk about kind of what to expect. What can you do on the early side? What if you, and kind of gives them some anticipatory guidance on, you know, what would happen if you had decreased supply, and start thinking about some of those things. This is just the plan of care I mentioned. Again, this is not a legal document, and it's really not intended to be a consent, but really just make sure that we're all on the same page. We've also found that this can be helpful. We have a lot of people that, if they call, there are so many hospitals in Houston, if they call an ambulance, we're not sure where they might end up for delivery. And while they try to deliver at the hospital with us, sometimes they don't make it. And this is just a way to at least show the providers there to start that, this is something that they've discussed with both their OB and PEDS team and is well supported. For us, we just put it into our electronic media system so that everybody is able to see that. And this is, we're able to see that consultation with PEDS retrovirology as well. In terms of management during a delivery admission, there's really no difference in management. We do make sure that their feeding choice is signed out. In our experience, some people who have decided to breastfeed may have suboptimal care if there's a provider that may not have been educated or kind of wasn't comfortable with this. And so it has helped us to make sure that both day and night teams are know about this and know to support it as they can during the whole labor and delivery and postpartum process. The diagram I show you at the bottom here is just an example. We had some questions from our resident teams about, mainly from the peds and neo sides, about, how do we, like middle of the night, what can we do to make sure that we're supporting patients in their infant feeding goals? And so this is kind of what came out of it, was a document that just summarizes kind of where they need to look, which for us is just look for that plan of care. And it reminds them that they have already talked to the PEDS team as well. And then it shows kind of, okay, so once baby is born, if there is any question, the nursing or provider teams can look in a variety of places in the health record to make sure that those prenatal steps were taken. In our institution, the pediatric gives an additional medication. This is not standard, and I can tell you that the perinatal guidelines, or the guidelines for the pediatric guidelines, sorry, do not specifically say what to do with medications. As I mentioned earlier, there is that data that just basically shows that maternal antiretroviral is basically equivalent to infant, but this is very, very location dependent, and depends on the PEDS team that you're working with. And then in terms of monitoring of the infant, this is where the question always comes up with supplementation. And I'll have to admit, at our hospital system, this has been like a hard stop, was, oh, you absolutely cannot have any mixed feeding or replacement feeding during the early time period because of the risk of transmission. And so we have worked really hard to get past that. And so what we're doing is, one, just making sure we're supporting exclusive breastfeeding, as we should be doing for anybody who desires that for their infant feeding, with early lactation consultations, early pumping if needed, and for supplementation, the things that we have found that come up most commonly with our patients include dealing with hypoglycemia. And this is just kind of an outline to encourage, residents in the middle of the night with hypoglycemia. You don't need to go directly to formula. There are some other things that you can do. And if you do need to use formula, no problem. Just make sure it's in physiologic volumes to try to encourage establishing that breast milk supply as much as possible. Same with excessive weight loss. I think within the last year, I've had a nurse be like, well, baby just looks hungry, and baby was up like 5% from the birth weight on like day of life too. So you always wonder about the scales in those settings. But it's really trying to get past that, hey, we're not just going to do this for a fussy baby. Of course, if a baby needs supplementation medically, give baby supplementation, and we are completely fine with formula. We are working on trying to include these moms in our ability to give donor milk, but I'll tell you right now, our donor milk supplies are so limited that it's really going to be on a case by case whether it's available or not. We're having issues finding enough donor milk for all of our indications right now in the NICU. And then NICU admission, this is just something to think about if a baby does have to be monitored in level 2 or in the NICU, just making sure that you're really intentional about involving the parent, making sure we can still support breastfeeding and establishing that breast milk supply as much as possible. So again, this is not a perfect answer, but is kind of what we're doing and trying to get the residents and the whole medical teams from the OB to PD side on board with this. So with that, I will just quickly go to these questions. I don't know, I can't see the chat, but if anybody wants to come off mute, or I'll give you a couple of seconds. The risk of transmission by breast milk for someone on antiretroviral therapy with a consistently undetectable viral load is which one?
D.
Excellent. Is formula always acceptable, feasible, affordable, sustainable, and safe for people in the United States? Okay, I'm going to say false. I hope I demonstrated the arguments, why not? Reasons that people with HIV choose to give breast milk to their infants include all of the following. So, and I hope I gave you some examples about this. And with that, I just want to say thank you so much for having me. This is my email address. If you have any other questions or things that come up afterwards, please feel free to reach out. And with that, I will turn the floor over to Cece to tell us a little bit about her journey and her story.
Okay, thank you so much, Jenny, for that. Thank you all for having me today. We're in the home stretch of a Friday, so we got this. Thank you so much for joining this discussion. My name is, as been said, is Sierra CC Coven. I was diagnosed with HIV in 2008, so I'm going on my 15th year. I was 20 at the time of diagnosis, which was before I had even considered having children. So that was that was the first question that I asked, will I still be able to have children? So back in 2008, the answer from the small rural town that I was at was like, But, you know, in 2010, I was able to have a child, and I was lucky to be with a provider who knew that I didn't necessarily have to have a C-section, and I was I was afforded the opportunity to have a vaginal birth. During that time, nothing about breastfeeding came up, like no conversation, no anything. My child was premature, so he immediately went to the NICU. But by the time I reached him, he already was taking formula, and no one ever questioned or mentioned breastfeeding. I knew that it was one of those things that would have changed because of my HIV status. I knew that there was something that I would no longer be able to do. It was not an option. So, you know, it was kind of the energy around it. I felt like providers were saying to me, like, you know, just be happy that you were able to get pregnant. Just be happy that this baby was able to come here without an HIV diagnosis. And there was this total disregard for the want or the desire or the swollen boobs, the milk pouring out in the shower, the depression, postpartum blues, and just that lack of connection that I felt with my son at the onset of his life, which still saddens me to this day. I cried a lot because I felt like my body was good enough to carry this baby, but it was too toxic to feed this baby because of my location in the world. Later on in life, I was able to see or start hearing stories of women who looked like me in different parts of the world who were breastfeeding while living with HIV. And I couldn't understand how come this person looks like we could be related, and she's getting the support to feed her child, and I just couldn't understand that. It was not until a presentation that I gave with the Well Project in 2019, I believe, at the U.S. Conference on HIV and AIDS with Mary L. and another community member, Claire Gassamagera, who's African, and speaking of these cultural reasons why someone want to breastfeed, or that there are benefits for the parent if they breastfeed. When Marielle said that, I was like, benefits? Wait, there could, because I had only seen myself in the context of birthing a child is like a risk to that child. It wasn't like I could benefit or anything good could come out of this other than my child being HIV negative. And so in that meeting, that conference presentation, I just really like, whoa, well, it sounds like we're getting closer to maybe breastfeeding being an option. I'm going to hold off to have any more kids until, I could experience that, because I felt like there was one piece of my life, like HIV had totally taken it away. So then in 2020, the Well Project sat down with the international community of women. I see Martha in here now, North America, and we sat down and we really honed in on this topic. There's like 23 different experts, multidisciplinary, and we really honed in on breastfeeding and HIV. And within that, it felt really good to hear that there was support from people who, sometimes they wear the white coats, or somebody that didn't look like me, not a community member. We're valuable, but that's not always the people who get listened to. So the people who I felt like had a voice, I had some of them on my side, like, yeah, there may be some benefits, there are benefits for mother and child. And, Black women and Black infants are suffering so much in these areas. Some of these things can be fixed by breastfeeding. I was like, whoa. So it was not intentional, but at the beginning of 2021, I became pregnant with my youngest child. So they're like 10 years plus apart. And now, after having all of this knowledge and information, I now had to make a decision of how I was going to feed my child. Not an easy one, but I had to make that decision. I knew that I didn't want to go through what I did with my first child, to the point where I felt like everyone else could do for him what I could do for him. Because all we're doing at this point is making a bottle. Like, what does he need me for anymore? Take the baby. He doesn't need me. And it's just so sad, like, to even relive those moments in my mind. But now with this baby, I was like, okay, yes, I got folks behind me. Some people are talking about this. I'm really hype. Let me go to my provider who I've had for HIV provider who I've had for the last decade. I see my medication says that it should not be used if you are breastfeeding. So let me go get my medication changed. It was breastfeeding or pregnant, so I knew that it needed to be changed. So I get to her, I say, yeah, I'm pregnant. My medication needs to be changed. She fixes that with no problem. And then I go into the breastfeeding conversation, and the redirection that attempted to occur. She's like, first, no, well, what about milk banks or milk donors? First of all, I don't want to feed my child someone else's milk. Like, kudos to those who resort to that because they have to, or because that's what they want to do. But I don't want to feed my child anyone else's milk. And where do you even get milk from? I heard, like, where do you get it from? So that seemed like an unattainable option. And then it went to, well, if you do this, then it's something that you're going to have to be quiet about, because if you aren't, then our pediatrician is known to call DHS, or the Department of Human Services, Child Protective Services, on parents who decide to breastfeed while living with HIV. I mean, at this point, I'm 6 weeks pregnant, and we don't even know if the baby is going to stick yet. And you're already talking to me about DHS when I clearly can raise kids. I have a 10-year-old who's doing amazing. But because of my desire to breastfeed and my HIV diagnosis, those things in culmination now, I'm threatened with criminalization. That's scary. And then the third thing that was said to me was that there would be no doctor in America who would work with me if that is what I wanted to do. And I knew that that was untrue. I live in Philadelphia. I knew that was untrue because another advocate, Heather O'Connor, a white woman who lived in Virginia, she was able to breastfeed 2 of her children here in America. So I couldn't understand, I already got the sister over in Africa that I'm looking at that's breastfeeding while living with HIV. And then I'm looking at the white woman living here in America, hours away from me, and she's getting afforded this opportunity. What is different about my situation than either of these two women. And it didn't sit right with me. So at that moment, I had to make the very hard decision to leave my provider, who I had built this wonderful relationship with, who was inside of a clinic who provided dental and case management and mental health and labs and everything. It was like this one-stop shop. I had to stop that because of my desire to breastfeed. Didn't want to lose my kids. Even if this baby was not going to come to term, I didn't even want to be threatened in that way. So luckily I was able to link with a provider, an OBGYN, who from the beginning, we started having these conversations. I think I saw him in week 8, and we just kept talking throughout the entire time because my mind went back and forth, back and forth. Like today, this visit, yeah, I'm a breastfeed. This visit, I don't know about that. I don't know about that because I don't want to be the one. And I just went back and forth, and he did the flip flop with me. He allowed me to be able to make my own decisions. And not only did it just come with an OB, I got like a high risk nurse and a social worker and like all of this support around the time that, you know, you're already so vulnerable and then have so many things going through your head. So I'm grateful for that. Then from the OBGYN, I was able to get an infectious disease doctor who just watched my labs the entire time, just make sure I'm undetectable. And that was the onset of my trauma, was my HIV provider, the one who wouldn't even be seeing me the entire pregnancy and watching baby. It was the person who had been providing care to me for all of these years. So ID got them, OB got them, and then I was able to link with a pediatrician, Dr. Lowenthal, who she supported my decision. We started talking around week 28, I want to say, you know, have you made up your mind? It's okay if you haven't made up your mind. We just want to make sure that everything is in line when you do go into labor. These are the different options of regimens. And she explained, you know, everything as cohesively as I would have ever wanted or expected. And I just appreciated that space. So baby was born in September of 2021, and we breastfed for 7 months. It was the scariest, hardest, most, anxiety-ridden decisions that I've ever made in my life because of so many of those unknowns. And also the feeling of, you know, you've already had a provider tell you one time or a few times that, you know, you shouldn't be doing this. So now I felt like if a transmission had occurred, then it was all going to be my fault, that I had done something that was wrong, that I didn't love my baby. And like just working through all of that can be so difficult, but having that support of community providers, being able to have a say so in what I wanted to do with my body, and like with the undertone that I care about my kids. Like I don't want a transmission to occur either. Like I care. So because I don't want a transmission to occur, I'm gonna do everything you told me to do. The things that we know, I'm gonna make sure that I continue to take my medication every day. I'm gonna get a baby the medication however much is required. We're coming to the doctor at least once a month for her. And then I'm getting my blood work checked at the same time. Like there were so many things, and it was not easy. That exclusive breastfeeding part was hard. Maybe I would have fed a little longer had we had more information on what that looks like, mixed feeding looks like, because a little person depending only on your body for to sustain their life is hard. So first baby didn't feel like he needed me, but this baby definitely needed me. And that was still another different type of stress that I was not prepared for. We did it for 7 months. Baby is healthy. Baby is thriving. Baby is well. And I feel so good to be able to encourage, you know, providers to listen and, you know, not feeling like you're in a space of allowing someone to do something, or that your personal biases come into those, or, you know, maybe you wouldn't have moved like that, but that's why you have your life to run, and you're just helping me get to where I'm trying to go. And I enjoy being in a space of helping other parents advocate for agency over their own bodies, their own lives, their children. Because essentially, I think we all went the same thing. Like, we want baby to thrive. We want parents to thrive. We want the best for them. And those decisions can't be laid in the hands of, others that are outside of you. And I'll leave with this one piece. The people who allowed me to make my decision, who solidified it, were other women who were born with HIV, who had fed their children from their bodies, who breastfed. It was so paramount to me because as a person born with HIV, you know what this experience is like over a lifetime. And you are willing enough to put enough trust and faith into the science or the experiences of others to take that risk. That helped my decision become so much easier. Because really, is an HIV transmission the worst thing in the world? Is it? And I think that question is one that nobody's going out to transmit, but is that the worst thing in the world? And to me, I had to really play it over again and again in my mind and took the risk, and baby, it's still negative. So I'm so grateful for that opportunity. I'm grateful to be able to speak with you all today. And that's all.
Cece, thank you so much, not only for sharing your story, but also being an advocate for yourself and for others. And Jenny, thank you so much for your informative presentation. At this point, we are happy to take questions. You can either put them in the chat, you can raise your hand, you can just come off mute and chime in. But let's start by giving a Zoom round of applause to our amazing speakers. So there are lots of people in the chat thanking you, Cece, for your talk, and thanking everyone for such a powerful and informative session. You stunned them into silence, guys. This is normally a very talkative group.
I'd like to hear our first speaker's impressions of our second speaker's very wonderful and informative talk. How did you hear that as a clinician and a scientist?
It's heartbreaking. It's really, as someone who's been privileged, lucky enough, had the honor of caring for many pregnant people with HIV. It is really hard for me to hear someone like completely discounting someone's own desires about how they want to use their body. And I also know, from my training, I was lucky enough to work with Dr. Judy Levison. And I don't know, not everybody has that opportunity and is exposed to such things. And it's really hard to, it's kind of a daunting process to think about how are we going to get this to everybody. I think hopefully the guidelines, especially in some of the big cities, will get the word out and hopefully start getting more providers on board with supporting this. But it's a lot of people to reach, and I'm not exactly sure about how to do that. But I mean, it's so inspiring to hear how you were able to meet all of your goals, Cece, in your second pregnancy. And it's worth the hardness to help patients meet their goals.
Cece, thank you. And what are your thoughts about getting the word out exactly like Dr. McKinney is saying?
We as advocates, in my role at the Well Project as program manager, I get to lead our breastfeeding program in this one. And I'm excited to reach the folks. I feel like kind of have some armor, somebody behind me. It's just not community. A lot of times finds out things before it like reaches the research books and all of that. So, you know, we probably knew you equals you, but way before you equals you became a thing. And the same thing with this. So kind of having it support, it puts a fire up underneath of you, because I'm not just speaking out of my mouth. Like, these are the things I know, I've experienced it. And now look, I have the white coat and initials behind it, if that's what you need to, you know, to be on board. But sometimes that isn't even enough. So I think we all leave here with the responsibility of spreading information, you know, and true and correct information to our colleagues, because Jenny and I are not going to be able to reach everybody alone. But, you know, becoming curious and researching. The Well Project has a great resource list. I'll put that into the chat in a moment, but a great resource list where you can read up their talking points for parents who are living with HIV, who can bring these conversations up to their providers. We're working on the provider facing content, or there's pamphlets that just some little facts of breastfeeding and HIV, things to be considered, just opening and expanding that mind a little bit. So thank you, Jenny. Thank you, Judy. Thank you, Martha. Like, everybody that's been a part. I met Janelle at the international conference just now. Like, it's literally going to take all of us.
And I do hope that the shift in the perinatal guidelines will foreshadow a shift among providers, because I think providers in general rely heavily on all kinds of guidelines, both medical legally and also to inform our understanding of different issues and how best to recommend care for patients. So I think hopefully this will lead to a lot more open-mindedness among providers and more patient-centered care. Any other questions? Thank you for that link, Cece. Leslie, I see you're raising your hand.
Hi, thanks to both the speakers. Just really, really wonderful, important work and experiences to share. I'm just really wondering, because both of you spoke so much about the education that still needs to happen. Education for providers, I think, you know, for counseling women and really being partners with women, but also, you know, and I'm trying to think of, I'm from OAR at NIH, I guess I should have said that. I'm thinking about programmatically, like how we could support that. The Office of Research on Women's Health has an R25 program that is for developing curricula, which we support for medical schools that could come at something like this. But also, what kind of education from your point of view needs to happen, you know, getting at the criminalization aspect of this and people calling CPS. Do we need concerted education efforts for CPS, for the people administering the services that are so critical for all people, birthing, pregnant people living with HIV? I'm just wondering your thoughts on that. And thank you.
Do you want to go first?
You can go first.
Well, I like to take things back really basic, real quick. I think it's disheartening a lot of times to hear that so many providers receive their HIV and AIDS education like all the way back then. So I feel like starting there sometimes, like building some curriculum in to go back, like updates on what's going on, because I feel like that is what has happened in so many cases that I've come across. Is it's just outdated information. Or someone was talking to a provider in a clinic the other day and they told them, yeah, we support, and they were actually encouraging the mixed feeding. And I'm like, whoa, 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 I'm not even a provider, but I know that doesn't sound right to me. So I don't know. Basic education, getting those new providers, new doctors and everything up to speed, I think will be so critical to this.
Yeah, I agree. I think we have to start at the beginning, and it can't just be a one-time one lecture or one series of lectures in med school. I know I try to work with the residents and fellows and, but it's also, colleagues, and some of talks like this kind of help. But I think, definitely implementing things. And I think similar topics like just making sure that people, like, evidence-based guidelines are there for a reason. And if there's not a good evidence base for something, or if that evidence base changes, it's okay to change. And I think that concept too, I know one of our local medical schools is trying to incorporate more like case-based learning in their first like preclinical years. And I'm hoping that some of those, instead of just like, here's a PowerPoint with the 5 things you need to know about, risk factors, blah, 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 medications, like hopefully that higher level thinking will help. It's interesting you bring up the education with CPS, and this is something I work very closely with our program for pregnant people with substance use disorders. And we have tried tirelessly to try to get input prior to delivery from CPS. And it's been really challenging for a variety of different reasons. More just like we're having trouble finding like a champion because there's so much turnover and things like that. But I think, we've definitely done sessions with whoever we can get from CPS to increase education. And I think that is also extremely important. If anybody has any other ideas about how to
requirements. So American Academy of Pediatrics, ACOG have annual requirements that providers complete in order to maintain certification. And inserting this as a topic, while you get, at least for ACOG, you get to pick which topics you review, offering this as one of the options within obstetrics, I think would be both a topic of interest to the majority of obstetricians, but also a really important review, again, because for individuals that graduated from medical school 10, 20, 30, some even 40 years ago, what we learned then is so different than what our reality is now and the evidence now. And hopefully people are reading the guidelines, et cetera, but the kind of the lowest common denominator of those that are certified practitioners is really CME, and making that an important part of it. Just a couple comments in the chat from Julie Orban. Agree, existing providers as well have gone through the medical education and need a refresher. Some of us have been out of school for a while. Yes, agree. And from A. Resnick, we need to find ways to get education out beyond medical schools to WIC and other MCH programs through nursing, lactation consultant education, et cetera. And I think that's another really important area of providers that need education. We actually had Jenny and Heather speak yesterday at our hospital to reach out mostly to our NICU and lactation and nursing staff to help provide education there around this shift. Granted, we've had patients breastfeeding for years, but sometimes with mixed support on our postpartum unit. So we're working to more actively combat that. I welcome other comments or questions. We're almost at the hour, but this was such a fantastic talk. Julie?
Yeah, this question is, hi, I'm Julie Orban from DC Health HOSTA. And this question is actually for Dr. McKinney. I was wondering if there were any incidences or instances where you have a patient who you've gone through the treatment plan, or this, you've developed a plan during pregnancy for breastfeeding, yet the patient ends up delivering at a different hospital where you wouldn't deliver, and how would that, I'm just wondering about the continuity of care for that particular patient, if that has ever happened, and the follow-up, if they've delivered elsewhere and they have a different provider delivering them, and postpartum care and breastfeeding support.
So it's something I'm pretty upfront with my patients, is I can't guarantee the experience that they would have anywhere else. I know in general, like, ignore the breastfeeding part. Unfortunately, there are places when people deliver in the city of Houston, they are treated differently based on whether or not they're living with HIV. And I think I've had one who wanted to breastfeed and ended up delivering elsewhere. They have that copy of the paper with them so they can show them. And what I usually do is I put my business card with my cell phone number in an envelope. I ask them please not to sell it, but give that to them to give to their provider team, so that they will call me, and hopefully I can help advocate for them as much as possible. If I know someone has to deliver at a different hospital, for example, I have a baby with complex heterotaxy right now that's going to have to deliver at a different hospital in our city for fetal reasons. I'm doing sessions on the front side with everybody from, OB, peds, neo, nursing, all of the educators and lactation, to hopefully answer some of those questions and combat some of the discomfort, which will come out as lack of support to the patient. But there's no good answer to how that combats. But yes, I have dealt with it.
Any last questions? We're a little past the hour, but well, feel free to reach out to either of our speakers via email. Thank you all for attending. This is always a special March talk for National HIV, or National Women and Girls HIV Awareness Day. I always get the order wrong, but close enough. Thank you all for attending, and have a great Friday. Have a great weekend. Thank you again to our amazing speakers.
Thank you so much.
You.